Hi, welcome back. In this lecture, we want to take a look at some necessary steps to moving more toward an evidence-based practice system. These are steps that Dan Spake came up with. Again, a physician in Arizona, emergency physician, who spent a lot of time looking at EMS outcomes and being very involved in doing clinical research. And he's come up with really these few steps that are very important that he sees as kind of the way to move in that direction. So the first step is a critical evaluation of literature. That's the first thing we have to do when we look at trying to evolve a new practice. That means every potential clinical condition we need to look at. And there's some efforts been underway to actually do that sort of thing. And looking at the evidence-based practice, the UNC Evidence-Based Practice Center has actually determined there's 121 different approaches to rating individual study quality. So there's 121 different ways, but only 19 of these ways actually met the standard for proper assessments. So there's definitely some issues in terms of the methodologies people use to make a determination in terms of review of literature. The second step is a critical evaluation of the cumulative evidence. How do we put it all together? How do we look at the body of knowledge? How do we do meta-analysis? Here again, there's 40 methods that were identified by the Evidence-Based Practice Center, and only 8 of these met proper assessment techniques. The third step is the critical evaluation of the chain of evidence. How do we look at how it's evolved over time? This is very important again because, as we mentioned in the earlier lecture, we go from laboratory or bench studies, often referred to as animal studies, to human studies with clinical trials, to guidelines applied across a broad population, and sometimes in that transition process we have a complete breakdown. We may do the bench research and automatically put something in place because of that without actually ever making or evaluating whether it works in true clinical practice. So we need to look at this chain of evidence and how we progress from the bench research all the way to the patient, the bedside, and how efficacious and effective the potential modality actually is. Then the fourth step is critical evaluation of the pre-hospital implications or environment. The real world, again, the efficacy, the effectiveness. It's not enough to say that it's effective and efficient in the hospital setting and automatically do it in the pre-hospital environment. We need to look and see if it truly makes a difference to do it in the pre-hospital environment. If not, again, it relates back to the financial issue. That's part of the efficacy here. It may make sense, but it may be a tremendous cost to implement it in the pre-hospital arena when that really doesn't influence the overall outcome of the patient in the long term. And we've seen that in several different situations. Again, the one I mentioned in the previous lecture was the use of thrombolytics in the pre-hospital environment. And there's several other studies that kind of duplicated that had that same outcome when we looked at it in the different environments. The next step, step 5, is a critical evaluation of other pertinent issues. And even if we do use it in the out-of-hospital environment, it may not be correct for your particular pre-hospital environment. We need to look at rural versus urban. Does that make a difference? Does the demographics make a difference? We see different comorbidities in different places, different communities. How does that play into what we're considering doing? We need to look again at the patient populations. The cost effectiveness varies with the prevalence of something in a given environment. If you work in a demographic area or market area that has a very low prevalence of something, then it probably doesn't make a whole lot of sense to spend a tremendous amount of funds in your organization to teach your paramedics how to do something that they'll never utilize. The socioeconomic impact, the at-risk population, again, how does that exist in your given demographic area related to comorbidities? The impact of delaying an intervention, again, that I mentioned in the previous lecture. Aspirin is another good example. The implementation of aspirin in the pre-hospital environment is very important. Probably the most important thing that you can do, not probably, it is the most important thing, most important intervention for a patient that has acute coronary syndrome and an ST segment elevation MI taking place with an occlusion, because it's the drug that not only creates the antiplatelet agents or the antiplatelet effects to the agglutination effects to break down the clot that exists, but it has the effect of preventing future clots. So in terms of mortality, it's the most important thing you could do. On the other hand, some of the other interventions, like the intervention of fluids in the pre-hospital environment prior to getting to surgery, may not make a difference. So we need to look at the location and see if it's the right intervention as well. We need to look at the risk for harm. Could something happen in the pre-hospital environment that's not as likely to happen in the hospital environment? And is that a reason to withhold that treatment until the patient reaches the hospital? The feasibility, the practicality, x-raying a patient may be very worthwhile, and we definitely have the capabilities that could be available to do that in the pre-hospital environment. But it's very costly to put a radiography machine in your ambulance or to put a CT scan in your ambulance when we can hardly afford to put them in the hospital environment. So you want to consider that as an issue too, the feasibility versus the practicality, and then value judgments in terms of your demographics as well. So there's a lot of things to consider in terms of making that determination if it's best for your organization. The sixth step that Dan points out is the evaluation of whether a guideline is appropriate at all. Is the evidence strong? Is it weak? What does all of the evidence look like? And how is it that if we have consensus, is it truly based on a guideline, or are we just doing it because it's a consensus statement? And if it is, then there may be justification for not doing it. But that's where you need to be in the conversation that needs to take place at the local level to make those determinations. The seventh step is to plan for recurrent future evaluations of the evidence and revisions, because things do change over time. And sometimes, again, we've seen treatments that were class 1 interventions with class 1 level evidence from the American Heart Association move all the way to class 3 as being potentially harmful. So you want to have that plan in place for how you're going to review and update and revise your clinical standards within your system. So the huge questions are we sure that we have evidence-based guidelines, or do we really mean consensus-based guidelines? Is that really what we want? What we really want is evidence-based guidelines. So we have to determine, will our protocols be developed and supported based on evidence, or will we utilize opinion? So I'm going to stop there, and in the next lecture, I want to end by actually giving you a perspective of a way to approach this